The webinar will now begin.
Good afternoon, almost everybody. I guess everybody except Hawaii or Alaska. Welcome to the third of our three-part webinar on navigating medical necessity in 3 acts. Next slide, please. Today, we're going to spend a lot of time talking about denials and appeals. We're going to take a couple little detours that we thought were important to include, including one on sponsored tests and then one on what's going on in the world of nutritional specialty formulas. And we'll close out with word from our family partner today, because I think it's really important for us to ground ourselves in how the work we do as providers, if they're both the Catalyst Center and the National Coordinating Center for Regional Genetics are HRSA-funded programs, and they've come together to support this work, which has been a great and fun amount of work for us, coming from hopefully from both sides of this. And it's we've learned a lot and are thankful to our HRSA partners for supporting this. Next slide. This is available for CME, which is through the American College of Medical Genetics, and it is available for 1 AMA Category 1 credit. And to claim your credits, you need to complete the activity and the evaluation form. And the deadline is 30 days from the activity. So do it today. Next, please. Our team, this team has been, I feel like we've formed and stormed and hopefully performed, and it's been a great team to work with, both from Catalyst and from people associated with the National Genetics Collaborative. So we want to say that we don't have anything new to say about financial disclosures, and most of us have nothing to disclose. Julie works for Garden Health and is an employee there. So next slide. Our learning objectives. We hope that at the end of this, you know what it means when a prior authorization is denied, identify where to begin the appeal process, list the steps in the process for an appeal, and describe options if an appeal is denied. Next. The crew is here. I'm trying to think if we're missing. I think we got almost everybody. Unfortunately, Nicole is tending to family work today, and she won't be available to us, but many thanks to her. And then beyond the presenters are the crew at the American College of Medical Genetics and Genomics, and at BU, Allison and Meg and Megan and Molly. So thank you. Let's keep going. Recordings are available from the first 2 sessions, so please feel free to go over there and look at those. And next, off to the material here. So we wanted to start this session about denials and appeals with talking about if a test or a service is approved, and remind everyone that approvals go through and often go through with a specific window of time, and sometimes, depending on how busy families are, and how busy schedules are, that approval can get done within that period of time, and hopefully that's the case, but it's something important to pay attention to. Next, we also really want to honor the idea that for families who have copays or co-insurance, that can be significant and or overwhelming. So we wanted to point out that there are a couple different groups that can help with copay and co-insurance. One is actually this organization called the Patient Advocate Foundation, and it was interesting. I always want to know that these organizations operate independently from anyone. So I don't know if you folks know, but you can find tax forms for every nonprofit in the country, and they seem to be fairly careful about keeping a distance between their donors and the services they provide. Nor does National Organization of Rare Diseases. I'm sure many of you know that as well. Next slide. So off to the part of this when authorizations are not approved, and we'll talk about denials, and we'll talk about the appeal process. I wanted to some of this is material that I hope you'll log and keep with you, or understand some of these limits, so that you know as we go along this, because there's a lot of numbers in these today. Learning that an authorization was denied, your health plan is required to let you know within 15 days if you're seeking an authorization prior to treatment, within 30 days for medical services that are already received, and within 72 hours for urgent cases. A denial letter goes to families, not providers, which can be tricky sometimes because the providers don't always know, although sometimes there's a consent that goes through that. And denial letters always include, or are supposed to include, appeal rights and timeframes for these appeals. Next slide. There's terminology that we use related to denials, and in our world, they're called, in most of Medicaid, and I think in most of commercial world, they're called DTRs. And that means denial, termination, or reduction in services or payment. And this is what, quite honestly, managed care organizations are required to track some of these and report them in or have them available. Federal and state law and Medicaid managed care contracts require MCOs or send a notice of action when these happen, and this is a significant legal requirement. And they also have to include some education about the right to file an appeal if the member disagrees with the MCO decision. Next. There are some terms in here that I just wanted to, I think many of you probably know what these are, but these are some of the common reasons why an MCO will say that something has been denied. Not medically necessary, experimental or investigational, and that we could certainly talk about that a little bit. For research purposes, if it's for greater like the research, if someone's in a research study. Incorrect level of service, so somebody may be requesting more service than is allowed, or than is in or than is expected to be given. And the last one I'll say is administrative denials for inadequate information. And I think that this last one is really annoying to people, but is one that is not terribly infrequent. But I think we talked some last time about prior authorizations and make sure all the information is in there. And I'll just say that sometimes this can gum things up. Next. I wanted to take a little turn before we talked about appeals to talk about who can help. And I think this is really important because those of us who are on this call probably already have some level of expertise around understanding prior authorization and denials and appeals. At least we know some of the terminology, but a lot of people, especially families, don't. Ombudsmen's exist, and they really have a very important and strong function, and we'll talk about where they exist in just a sec. But an ombudsman is which is a hard word to say 10 times fast. But they are someone who's appointed to investigate complaints against an institution and seek resolution of those complaints. And so it's a term that's obviously not just for healthcare, a lot of ombudsmen in education and in other areas as well. There's some key characteristics of ombudsmen: independence, ability to investigate complaints, which sometimes includes subpoena power, ability to criticize government agencies, and to recommend changes that may be used in public reports. However, I think this is important. Ombudsmen don't have enforcement or disciplinary powers, but I'll just say that I think ombudsmen carry a lot of weight in what they say and how they can support the work. Next, ombudsmen in healthcare can some of the same themes, but states are required to have managed care ombudsmen for Medicaid. They can be a problem solver, a neutral investigator, an advocate for fair and equal treatment, and ombudsmen can be confidential. One of the things I want to just mention here that I don't have on a slide, but I think is important, is an ombudsman's office can be in a lot of different places. It can be at a managed care organization, can be at a state agency, it can be privately funded, or it can be an independent agency in the state as well. But all of them are supposed to have these characteristics so that the people who are served actually have a neutral party to help. So next, this is a little bit more specifically about beneficiaries with MCOs. And some of these things are duplicative, but I'll just highlight that they can investigate complaints. They can explain how to file a grievance, appeal, or fair hearing. And they can help you. I think the most important thing is they can help folks who don't understand the healthcare system understand it. Next, I'm going to turn this over to Julie for a minute, who's going to talk about the commercial side of looking for help.
Sure. And so with our commercial health plan or insurance payers, they all might have different resources available or might assist this appeal or complaint process differently. So it's important that patients and you guys as providers kind of investigate on a case-by-case basis, but there are some common generalities to be aware of that might help you go through this process and know who to reach most efficiently. So within a health insurance plan, there may be care managers or case managers. These are traditionally professionals trained in care or case management who are assigned to and then ultimately assist individual members who might be navigating complex medical conditions. So things like diabetes would be a common indication for someone to be assigned a care or case manager, or someone that has frequent interactions with the healthcare system. But certainly complex genetic conditions would fall under this definition as well. So there might be someone available to help navigate your patient's process through this appeal journey. There are also healthcare advocates or member advocates. These are professionals who are available at a health plan to explain and assist with issues. And so as you encounter a denial for maybe a genetic test that you feel is medically necessary for your patient, you can advise them to reach out to their, the number on the back of their card and ask for an advocate, a member advocate, or case manager to really discuss the specific denial and understand what appeal process or appeal rights does that member have. And they can ask on the phone, me as a member, and then also what appeal rights does my provider have? And those individuals can outline both of that. Something that most folks don't know is if you have a patient that has had a denied service that really that denial is impacting your ability to care for them, their employer HR team that actually picks and selects and designs the benefit would really like to know about this. So your patient can actually reach out to their employer HR team and say, hey, we have health insurance that doesn't cover this very necessary service. And here's the impact on me and my family by not having that covered. That employer HR benefit person might be in a position to carve out some coverage just for employees of their business. But it also can provide some valuable feedback and pressure from who are ultimately the customers of health insurance, being the employers. They want to keep these employers happy. So patient complaining doesn't carry the same weight as an employer complaining. And then finally, we had a discussion internally about whether or not to bring up this kind of niche area, but there are available concierge services. So these would be third-party, independent subscription or pay fee for service process that gives you access to professionals who are experts at navigating healthcare and will actually perform a lot of these duties on behalf of a member. So this can be cost prohibitive if your patient or family doesn't have additional resources. But in cases where medical needs and encounters with the medical system are frequent and vast, this can actually be an opportunity for a particular family that's struggling to help streamline the process and increase access and efficiency through the system. And while these services are available and perhaps cost prohibitive, it might also be something that different patient support foundations look into. Although we, on the payer side and provider side, want patients and members to be really careful when engaging with these concierge services and making sure that they are going through the system on your behalf responsibly. We don't want to inject unnecessary activity into the healthcare system. This should really be a solution to that and not a cause of abrasion. Thank you, Dr. Schiff.
Thank you. We'll go next. I'm going to talk about appeals next, but I wanted to talk what I called under the hood of the appeals process, and we did not have a card to show you, but I think you get the message. So just a couple things. The appeal comes into the MCO, public or private, or to Medicaid directly if it's a fee-for-service state. It's always reviewed at some level by a nurse or physician, and usually if there's a prior authorization and we go to this next step, the appeal is usually handled at a level with a higher degree of expertise. This is the thing I think that's really important, is that usually appeals are required by law to be specialist to specialist. And it's sort of interesting because I think some people who see complicated kids on a regular basis manage to set up these one-on-one conversations, and they know how to organize them in their offices. But I would say that specialist is a relative term, and speaking as a pediatrician, there were times when the specialist that I would be talking to would be an adult specialist. So you can always ask for a greater degree of specialization. But sometimes in small states, especially, there could be, unfortunately, 3 child psychiatrists or other things. So that can be an issue that gets to be specific. But it is important to have somebody who understands the case there. The other thing I put in here, just because before we get into the hood, is I would get into the details, is that managed care organizations really, they look at individual cases, but sometimes they think about the total cost. I don't know of anybody, I asked this question a lot of people who've worked as reviewers in managed care, whether or not they had any specific, criteria that they had about whether they had to meet a certain threshold or quota. And the answer was always no, but certainly if you're sitting in a boardroom at a managed care organization, you are concerned sometimes about what's going to be what's the budget going to be? And oftentimes, at least with us, when there was an expensive service that came in the middle of a managed care contract year, we had the managed care organizations asking us whether we would cover those things separately. But I'll remind people of something we've said in the previous two webinars, and that's that because we're mostly dealing with children here, EPSDT requires that children have all necessary diagnostic and therapeutic services. Anyhow, next slide. So I'm going to give Allison full credit for finding slides, and I'm going to tell you that since we're really going to talk about the first two steps way on the bottom here of an appeal process, these steps, which I did not know existed, are both poignantly and perhaps ironically in Odessa, Ukraine. They're the Potemkin steps that lead from the Black Sea to Odessa. And the other steps, I thought that for somebody who went to medical school in Philadelphia during the release of the first Rocky movie, I thought about the steps at the art museum there. But anyhow, steps. We're going to talk about the first two steps in the appeal process. Next, the first step is really internal review. And members can ask their MCOs to review and overturn a decision by filing an appeal within the timeframes we talked about. Members have potential to receive services they were initially denied, and they usually can file it by phone or in writing, although I certainly would advise to keep copies of what was done and the dates. These are the reasons the appeals category, this should be outdented, sorry, but billing and financial issues, like did you put the right codes in for a service? Out of network denials, are you asking for a service and then by a provider that isn't in the network? Services and benefits, that's where we're going to spend all of our time, and timeliness of service delivery, which we already talked about. 90% of appeals are because of services and benefits, whether they were appropriate services and benefits. And I would say that if you look at some of the technical categories that could turn down on prior authorization, I don't think they quite make it to the appeal process, but I think there's a lot of those things that need to get worked out as well. So we talked about, I'm going to go to the next slide. We talked about the time frame for letting folks know about something, whether something was approved or denied. And these are the time frames that are the minimums that for when an internal appeal must be completed after it's submitted. So 30 days if the appeal is for service that has not been received, and 60 days for service if the appeal has been received. And then the next slide, which you can see, I must have gotten off of Molina, so I apologize for that, but this is not specific to them. It includes all the demographic information and includes the primary care doctor's name and phone number, or the ordering physician, a description of the issue, and then any record related to the request. And most often that is a letter from the provider. And then I think I'm going to go back and just, I'm going to go to the next slide, but just remind folks that this is perhaps more specific, but very similar to the request for authorization itself. I think it's important to check your appeal letter, or the appeal letter the provider writes, against the content that's printed, even though those content can sometimes be vague. And if they are vague, I think it's really useful to take the criteria that have been supplied to you with the denial, hopefully, or that you can find on the website, and then go right to them, put them in quotes, and address them very specifically. Using the language that's already been created is a very helpful thing to do.
And Dr. Schiff, I just wanted to add one point of nuance here,
Sure.
is that if there's printed criteria or a policy, if it's a commercial payer, usually those are pretty accessible just by Googling medical policy and scrolling. If you see that your patient meets criteria and maybe that wasn't originally appreciated, it's a great use of your time to, go through this appeal process. If you see that this test is considered experimental or investigational, the test is never covered, and there are no medical necessity criteria, it can still be useful. And you might have an opportunity to make a policy change. It's just kind of however your practice weighs your availability in terms of time and energy resources. Thank you, Dr. Schiff, for entertaining that interruption.
Oh, no, that's totally fine. So I just think, I think the other thing I'll just say on this slide is it's good to understand, if you can, who is looking at these, as I said before, who's doing the review. And then also, if you're in an insurance plan, there are things to know, and I think probably many of you know that you could be in an MCO or in fee-for-service Medicaid. And if you're in fee-for-service Medicaid, your review is often done by either a Medicaid medical director or by someone who's hired by the state itself. If you're in an MCO, the MCO will do this internal review. And then I'll just say that for some states, for Medicaid, and for a lot of employers, we can get into this a little more if you want, a organization like Blue Cross or Aetna can serve as an administrative services provider, which means that they're actually processing claims, but the cost of care is paid directly by the employer. Next slide. We're going to move on and talk about external review for Medicaid. This is the most common. There's a lot of different terminologies in different states, but a state fair hearing is what it's also known as, or a state appeal. The member has a request that actually goes to an administrative law judge or somebody who has some neutrality, often at the state, and they can conduct an independent review of the MCO's decision. The member has the opportunity to present evidence to support his or her case. And these are actually, I wouldn't say that states have put some resources into this, and they are required. And I just put down here where they're required. They're required for Medicaid. They're required for anybody who has insurance through an insurance exchange. And ERISA are the self-employed plans. And since the Affordable Care Act, except for grandfathered plans, an external review is required. Next slide. I want to make sure we have lots of time at the end for discussion. So I'm going to just say that our timeframes, the standard review is no later than 45 days, and expedited reviews are within 72 hours. Next slide. A little more just on the perspective of the MCO. I put this in because I think we talked about this a little bit just to remind you, MCOs are kind of in an interesting position because, go forward. Yep, thanks. They have to decide sometimes what they want to cover, and they are, I think at their heart, MCOs want to be thorough, but at their heart, they also don't want to have an adverse patient selection either, where all of a sudden MCO is paying for a fuller spectrum, say, of autism services or a fuller spectrum of genetic testing, and folks decide that's where they want to move to, especially if they're at risk, without appropriate risk adjustment. The other thing I want to say is that MCOs will calculate how much time it takes to do an appeal, because it takes a significant amount of time on their side. And I already said this last bullet, which is that fee-for-service Medicaid will have a review process as well, either internally or via a vendor. Just a couple more things to say on this. I think one of the things we talked about last time, and I just want to say it again, ask for a single point of review if you can, because as we have talked as a group, and the best thing you can do is to find somebody who understands and then is able to actually move to facilitate or streamline this, so you get to another level of understanding at the insurance company or at the state Medicaid agency that can be more thoroughly cut to the chase so that you don't have to say the same thing over and over again. And I think that those relationships are really important. Next slide. We're continuing our architectural tour, and I want to say a little more about building a bridge to the managed care organization. Allison again found this, and this was the Python Bridge in Amsterdam. And I want to go there sometime to walk on this. And I'm just amazed that they can design things like that. So just a few things that I didn't say last time, but I think is important, is that as you build a bridge, the relationship between the provider in the community and the health plan can be important. And usually by the time you're getting to this level of detail, people know each other. And so it's sometimes is really relationship based, and you want to you want your credibility in the community as a provider to be well established. And I think that also includes disclosing any conflicts you may have and whether or not they've, what you do. So I think that's important. I also talked about these things before, about being respectful and understanding but asking for alterations in the process, asking for fast track status, and offering to share data back. But I also want to say one more thing, and that's that as you start to build this bridge, and I've been on both sides of this, and you go to an insurer and say to them, I really want you to think about this. I think sometimes you have to understand that they have a process internally and they're gathering information by meeting with you. They're going to take it back internally and have the discussion. And I think it's appropriate to ask them how long it takes to process it, not to make a decision in front of you while you're sitting there. Anyway, those are the two basic processes, the internal and the external review. And then you get to this point where hopefully things have been approved if they're medically appropriate, or hopefully people understand why they're not approved if they're not. And then there's what other things you can do. Next slide. If you run that course and there's still a denial. And so I'm going to turn this over now to Erin from Heartland, and she's going to walk through a slide we saw before, as well as some other information that I think is really helpful to think about what else could be done to help the families we're serving.
Thank you, Dr. Schiff. Next slide, please. If you follow this QR code, you're going to come across the Heartland Regional Genetics Network genetic testing toolkit. We provide a number of different resources here. This is kind of your decision tree that Julie had put together for our toolkit that explains, if things are covered, where do you go with that? If they're not covered, where do we go from there? But there are other pieces to our toolkit that help you walk through the prior authorization process, and those have been covered in our previous webinars. So please feel free to visit that site and take full advantage of all of the pieces to our toolkit. We would also love your feedback of any other items you would like to see as part of the toolkit. So what we're going to be covering today is, what do you do if there's a denial? What are our other recourse to moving forward? One thing that you could always do, and obviously this is not available to everybody because different people have different financial situations, but one option is to pay for the testing out of pocket. So that always is an option with genetic testing. Sometimes that can be navigated through a healthcare system. There are markups for genetic testing in many healthcare systems, so that's something to be aware of if you're ordering it through institutional billing as a provider. That's one thing that families should be ready for if that's your only way to order your testing. Some institutions do, I understand, instruct their providers to order through the laboratory for institutional billing regardless. Many laboratories in genetics do offer direct billing, or some people will call it third-party billing. And in those circumstances, oftentimes they may have marked down for patient pay prices if you're doing the third-party billing. So just know that that is an option for out-of-pocket costs. Some labs have out-of-pocket, like patient pay price, that's just a flat fee. So look at the lab that you're using, look at the way that you're moving, ordering your testing either institutionally or on a third-party bill perspective, and what the options are there to just go ahead and pay for the testing in that family circumstances. That's, like I said, not equitable for everybody. So not everybody's going to have the same resources. And we're going to look at other options. Let's go to our next slide, please. All right, so some other options within the insurance and within state services are what we're going to be covering now. I'm going to move to the second point first. So Julie previously talked about case managers with the insurance company. You can use case managers to your advantage here. You might be able to request like a one-time coverage of this service. That's something that a case manager would help you walk through if that process is available through your insurance company. So that's one thing specifically that could be asked about if the family has a case manager. If you're working with the family that doesn't have a case manager, encourage them to ask for a case manager. Another option, and this is true, these items that I'm covering here are not just specific to genetic testing. So if you're trying to get things like medical devices covered, these are resources that are applicable to that as well. And I know we're going to cover medical formulas after this section, but medical devices could be covered in these same ways. Do contact your individual state's Bureau of Special Healthcare Needs, because oftentimes the family advocates there within that bureau are able to point you in directions of resources. There's a number of different financial funding that might be available on a philanthropic standpoint or on a charitable standpoint. So they can point you in those directions. They may be able to help you navigate through state existing services that are outside of Medicaid or outside of insurance to help get what you need for your patient. In addition to that, do consider other options that are available to your family. Many employers do have employee emergency funds, not all obviously, but I would say some of the larger employers do have these available and may be able to use those funds to cover something that is necessary that's not otherwise covered by the insurance, such as genetic testing. Another thing to look for are condition-specific support foundations. So if there's a condition that you think is likely the diagnosis for the patient, look at what foundations and family support services are out there. Is there a group, and do they have any sort of funding for genetic testing? Some of those foundations may actually already have some kind of an agreement with like an academic laboratory as well that allows your patient to access some sort of subsidized testing. So look for those opportunities. Another thing that I'll add in here is that there are some insurance companies that do have funds. I can't mention any specific, but there is one big payer here that I know I've had great success in using their the Children's Foundation from their insurance to access covered testing. Basically, they just pay for the patient's cost. I think they will do that for copays, not just for covering full cost if the plan didn't specifically cover that test, but we have had in clinics I've been involved with success in using that. So ask the insurance company if they have any sort of charitable line to their insurance plan that's open to their participants. Next slide, please. So another option that you could look towards, without changing the test that you're ordering, is financial assistance programs. When you're working within a healthcare system and you're ordering as a like an in-house test or institutional bill, you probably have some financial assistance programs through your hospital system or your healthcare center that you're working at. And patients may have to apply for that. They may have to submit forms for that, but it is a way to get their test costs covered. And so that is something to know the resources within your own healthcare system that your patient is using, right, as a provider. The other thing that I would point out is that if you're using a third-party bill through a laboratory, many of the genetics laboratories these days do have a financial assistance program for patients. It varies lab to lab. Most of them require some sort of an application process. Most of them are using a sliding scale, not all. And you may or may not need your patient to submit financial documents to support their application. Many of these laboratories by law cannot say to the patient, do you want to talk about financial assistance? The patient has to say that to their customer service directly, or you have to inquire about that to the laboratory directly on behalf of your patient. So know that that's not something that's always directly said by these laboratories. So please, you kind of guide your patients that if they're going to be talking to the laboratory customer service, to ask specifically about the financial assistance programs if that's something that they need. Next slide, please. So if you visit our Heartland Genetics Network toolkit, you will see an Excel sheet that you can link to for sponsored testing. I have not put a picture of that spreadsheet here because it does have specific lab names. And of course, we don't want to have any commercial bias. But there are a number of laboratories in the genetic space that do offer sponsored testing. Let's talk about what is sponsored testing. So sponsored testing is generally free or reduced price to patients. It is being otherwise financed by another entity, typically like a pharmaceutical entity, but not always. Sometimes there's foundations for specific syndromes, like muscular dystrophy foundation, for example, that may be footing the bill for that testing. But there's a third party that is a financial entity in paying for those tests. Now they have preset what panel that they want to have available to those patients for that particular sponsored testing program. So there's not a lot of wiggle room on what you can get testing for. So this is not ideal in replicating exactly the same test that you maybe wanted to get in clinic and couldn't get covered. But it's better than nothing, and you might be able to get some answers to some of the genes on your differential. So it is a really great option to look into. I think we have currently on that spreadsheet like 63 different panels that are sponsored tests, again, free to patients. Most of these tests that we have on our list are going to be things that the patients, their information is still protected and they still maintain the rights to that particular sample. And any information that is shared with like a pharmaceutical company, for instance, if their purpose in funding this is to have access to data, that data is usually provided in a cohort and not like on an individual basis where there would be any identifying factors there. So the reason why these pharmaceutical companies are often making this testing available is because if patients have better access to testing, then a certain condition or certain conditions are going to be more readily identified. And then if those patients are identified, then they can get treatment. And so many of these pharmaceutical companies have the treatment that's available for whatever one or two of those conditions are. The other part of the panels may be similar conditions, and they're trying to distinguish between who are the patients that would benefit from treatment and who are not. So that's one of the prerogatives. Obviously, those companies can get, tax credits or whatever for funding charitable research. But do be careful as a provider. If you have a vendor come to you with sponsored testing, then ask good questions about what is the motivation for the funding of that sponsored program? Does the patient maintain rights to their data? What data is shared with that third party, if any, and how is that shared? So you want to look out for the privacy of your patient as well when you're dealing with those programs. There are some really good reputable programs that have sponsored testing, and then of course there's been programs where that's less than ideal. Next slide. I also want to bring forth that testing through research is another great opportunity. And I wanted to highlight the Undiagnosed Disease Network here. So this is a program where your patient does have to apply, but if they are selected, they may be able to access testing through that clinical research program. And then in that way, they are getting their testing. It's, the cost is offset to them, but they are still getting answers. One thing, there's other research opportunities out there, especially at universities or academic centers. But I want to caution that when you are referring your patients into research, make sure that you and your patient understand, are they going to get results back from whatever genetic testing is being done? Not all research projects where genetic testing is being done is the patient going to actually get results in the end. So make sure that that's clear. Make sure that the family understands the time frame and that you understand the time frame of any research opportunities. But otherwise, research opportunities are a great way, again, to have more accessible testing to patients. Next slide, please. And I just wanted to highlight a couple of other really great resources that can help through this process and navigating resources for families and providers who are working through this process. So you've got the Family to Family Health Information Center. This is federally funded. They have them state to state, so really great resource. And then you've also got the National Genetics Education and Family Support Center. So please do follow those QR codes as well. And that's the end of my part.
Thanks, Erin. We're going to turn it over to Tammy for a few minutes to talk about, we thought since this is timely and we have been following medical nutrition, we should make sure that we spend a little bit of time sort of kind of furthering that case. So Tammy, we're turning it over to you.
Thank you, Dr. Schiff. So in this slide, we'll talk about the medical nutrition shortage. In February of 2022, Abbott recalled EllaCare and a variety of other powdered infant formulas that were produced at their Sturgis, Michigan facility after 4 infant cases of Corynebacter infection were reported. And due to that recall of those formulas, the patients who normally would use those formulas had to utilize alternatives. The increased demand for the alternative formulas caused a shortage of stock in the supply chain that included also prescription metabolic formulas. Manufacturers are increasing their production as best as they can to keep up with the demand. Currently, the demand is exceeding the production capacity, which results in interruptions in availability. And because some manufacturers prioritize the hospital and retail suppliers, DME companies may have experienced a supply interruption while hospitals and retail stores did not at the same level. Next slide, please. So what are some of the options that families have in light of this medical food shortage? In certain cases, the families or the companies, and even not the companies, but families or individuals, as well as DME companies who provide these formulas to patients. One option is for them, one of those parties, to contact the dietitian at the clinics to request a new prescription for one of the available alternatives. And as I mentioned, this is action that's needed by the individuals, the families, or even a representative from a durable medical equipment company. Another option would be for the families or dietitians to contact medical food company insurance navigation assistance programs. These companies, it is in their benefit, obviously, because they are the providers and manufacturers. So it's in their benefit to work with patients to get the product to them. So because of that, they have specific staff that are considered to be assistance navigators. And what they do is they'll help the patients to connect with DME companies that can provide these nutritional formulas. In those cases, some of those are Nutricia, VitaFlow, and Cambrook, just to name a few. Also, families and patients can investigate local support programs, and these are often state-based programs. For instance, in the state of Georgia, there's the M&T for P program at Emory University, and I have indicated that website address there. This support program provides bridge formula for families while they're trying to get the new formula through their DME company, and will supply those bridges on a case-by-case basis, usually up to at least a 2-week to a 30-day supply. Families should also contact their WIC dietitians who can communicate and collaborate with their clinic dietitians to ensure that they have the medical food that they need during this time. And I'll now turn that over to our next presenter.
Great. We are nearing the end of our presentation and we have some questions. Well, I'll just encourage folks, if they have other questions, to put them into the Q&A or the chat. I think they're both getting monitored, but we importantly wanted to talk about how this whole prior authorization process looks from the perspective of families. And I really I'm thrilled to give Demetrius Nance our word on that. Hi there.
Hi, thank you very much. Glad to be on this webinar today. As a parent of a child who has a medical condition, just recently, she has, as you know, sickle cell is very out there and has very little treatment, but 3 medication has now come available for patients with sickle cell disease, and my daughter tried one of them. Once we took our prescriptions to the pharmacy, it was denied, saying it was not covered by our insurance company. I then informed our provider, who said he would need to do a prior authorization. My daughter, who is now in the prime time of her life, teenager, just graduated from high school, this affected her emotionally because she thought, hey, here is going to be the key from stopping me from attending the emergency room multiple times, pain management, not going into the hospital, and was told that there's a possibility that she would not be able to get this medication. And I had to encourage her to let her know that this is just not the end. We just have to let the doctor do his part. The doctor did an appeal, a prior authorization. It was denied again, stating that she had not had enough ED visits for her to be approved for this medications. And for a moment, it was devastating knowing that here's an opportunity of a new medication that could help her from going to the emergency room. So the doctor did another appeal. I, at that particular time, contacted the insurance company on behalf of my daughter as a caregiver and shared my insight about the need that my daughter would need this medication. After 2 months, the insurance company finally approved this medication, and now my daughter is now on the medication that will help her with her sickle cell. Lastly is a procedure that my doctor wanted to do for her back in January. It took 6 months, several appeals to the insurance companies. And, like I say, dealing with a teenager who is in the prime time of her life now, to have to go 6 months not knowing whether she'll be able to have a procedure that can actually answer some medical questions for her. The good thing is, by me being in the medical field over 20 years, I knew the process, which has been explained to us earlier, calling the payer, being an advocate for my daughter. But what happens to that parent or that patient that does not know the clinical background, not knowing what to do, when to do, or what questions to ask? One of the questions that were asked for me on the insurance company was, what is the CPT code for the procedure? If I'm not in the medical field, I would not even know what a CPT code was. So the average parent would not know those questions. So I'm very, very pleased to be able to advocate, because I know a little medical background. But this process can really, really be a hindrance on some patients. Now I'm dealing with my daughter being transitioned into adult, where she will have to advocate for herself. I can't answer a lot of questions. I can't go in a doctor's appointment. So how do I educate my daughter as a teenager on how to advocate for herself for a prior authorization or a medication that has been denied? Is a transition time for us as well. So this webinar has been very beneficial. I think we need to educate our parents in the beginning on what to do, how to do, and to educate them to read their policies so they can be well prepared. And just because it was a denial, it doesn't mean no. Thank you very much for your time.
Thanks, Demetrius. I admire your persistence and the persistence of lots of families who have had to go through this process. And I think that if anything, I think some of the things that have been successes in the last few decades have been the use of like the family-to-family centers and the ability of organizations like the Patient Advocate Foundation to really help support families as they learn about this as well. We have a few questions, and I just want to be able to go through them and see if there's any others. And before we wrap ourselves up here, Dr. McClellan, I think, had a question here that I thought was really timely on two things. One is, do you expect a geneticist to review an appeal? And I would say absolutely yes. And you could, I think that's important, and it's important to find out who's actually reviewing and ask for someone like that to review. I'm going to also talk about the second question, which is I guess I would say the hassle factor of trying to find payer policies and understanding them. And it really depends, I think, on how much work that is. But I do think that in the end, it's one of those, you have to dive into the pool, perhaps. Julie, do you want to speak to your answer that you put on here a little bit about that? Because I just feel like it's important to, it's a step further to go and find these things out, but it's really the step that patients often need.
Sure. Yes. I just think all of that in context of what your practice can handle, but there are a lot of activities that the family can be engaged with, and they actually have member-specific appeal rights that the lab and the provider don't have. So there's a lot of ways in which you as a provider can be involved, but of course, like our healthcare system can't hold that. You guys have to see patients all the time. So it's hopefully the information we're bringing shows that there are a myriad options and availability for you to come in and provide that really impactful activity, either in an appeal hearing, a peer-to-peer conversation, and asking for, true peers. And again, I put in the chat, don't sleep on, the fact that genetic counselors can be involved with healthcare companies, health insurance companies, and they can often be some of the most effective advocates for you. So don't feel like you have to, only pivot to an MD conversation if you feel like there's adequate understanding and explanation there. And then labs have people and money that our clinical colleagues may not have available to them. And it's their job to be aware of this insurance environment. So if you're getting information in a balanced way, then that can actually be really useful for you in your practice. If your laboratory is calling you to give you a heads up that this test might be covered, I feel like that's good for everybody, because you can then digest that information, communicate it with the patient, and then decide on your course of action. And it's actually something already happening in the prior authorization space. You might get calls from some of these benefit management companies saying, this test isn't covered, but if you want this smaller panel, maybe it will be. And so these are just a lot of different ways to make the most of your time and resources so that you're not getting burnt out, but also we can kind of direct families to be as active and helpful in this process too.
Great. I think I want to hit on the one other question that was in the chat that Julie, you also responded to, which is really a question about how to help. It seems like it's a question about laboratories and helping with utilization management and their sort of hesitancy about telling a provider how to practice medicine. And as I was reading this question, I was thinking about my life in the ER, where I worked in a pediatric ER, and I'd want to tell folks on the outside what they could do differently, and then the pediatric specialist would tell me what I could do differently. So I was, so you could be on both sides. That I think a lot of this can be around education, as I think Julie pointed to, and then talking about what the best options are in terms of educating the providers in a way that lets the information sink in and hopefully a useful way.
And just understanding the difference in the process and language used can kind of help us go from this adversarial, you're telling me this is research, I do this every day in my clinic, to understanding, oh, this experimental language means something different in the policy world. Here's how we can have a discussion about that, instead of arguing that this isn't experimental. We can say, have you seen this evidence? In this particular case, which your policy does not address, it's very well supported. Can we talk about an exceptional coverage? There's a lot of bridge between where we historically have been.
Great. We have one more slide, I think, and then we're going to close on up. And we hope that we have helped advance your knowledge of how this process works. We started off talking about medical necessity definitions and evidence, talked about EPSDT and Medicaid and collaborative agreements, and then really talked about the practical application of medical necessity around prior authorization, requesting authorization, denials, and appeals. And that's where we're landing. I really want to, I'm going to turn it over to Megan to close out. I want to spend a moment just thanking the folks on this team that put these webinars together. I think we all came at this from different expertises and saw this in different ways. And I hope that hearing these different perspectives was helpful to all of you. Megan?
Thank you so much. Yes, so I'm Megan Lyon. I'm the Associate Project Director of the National Coordinating Center for the Regional Genetics Networks, one of the organizations who was lucky enough to help convene this group and hold this webinar series. And so on behalf of NCC and the Catalyst Center, I just wanted to thank everyone who participated in this live, or if you're listening to the recording, which will be available both in the ACMG Genetics Academy and on the NCC website. Thank you so much for your participation in this series. This is definitely a continuing conversation. So we have listed some resources from our partners at the Heartland Regional Genetics Network to continue this. This information will also be available on NCC's policy education website called the Genetics Policy Hub, where we have the recordings as well as the list of questions that we received via this webinar series. So you can go and see what was discussed during previous webinars. And we encourage you to go and continue asking us questions. Please reach out to NCC, as NCC is tasked with providing education around genetics policy. We encourage further discussion and seeing where we can assist you all as a community. So we just wanted to thank you all for participating and thank all of our presenters and the team that made this happen. It was an incredible webinar series, and it wouldn't have been possible without each of them. So thank you so much. We hope to continue to engage with you, and please feel free to reach out to NCC with any questions. Thank you so much.